Welcome back to another Explainer. Today, we're tackling something that goes way beyond casual learning. We are mastering the critical, life-saving steps of CPR. Look, when an emergency actually strikes, chaos is the absolute default. But with the right structure locked in your mind, you can literally be the calm in the storm. We're going to decode the fundamental algorithms of cardiopulmonary resuscitation. First, recognizing the emergency. Second, the initial response sequence. Third, chest compressions by age. Fourth, airway and breathing maneuvers. And finally, compression to ventilation ratios. Section 1. Recognizing the emergency. Knowing when to act. It sounds like such a simple question, right? But in the heat of the moment, it's the absolute most critical one you'll ask. When is CPR actually needed? Because you definitely don't just start chest compressions because someone feels a little faint or dizzy. You need absolute, undeniable confirmation that the patient's physiological systems have failed and they require manual intervention. The clinical notes lay out very specific indications and signs. CPR is indicated for massive events like cardiac arrest, carbon monoxide or dioxide poisoning, drowning, or an electric shock. But what physical signs are you actually looking for in the patient? First and foremost, they are unconscious. There's no palpable carotid pulse, which means the heart just isn't pumping blood. You'll see apnea, meaning their breathing is completely suspended or absent. The notes also call out dilated pupils and cyanosis, which is that bluish discoloration of the skin caused by a severe lack of oxygen. Basically, if you see these signs, it is go time. Section 2. The initial response sequence, the DRS of CPR. Before you even think about putting your hands on a patient's chest, you absolutely must run through the DRS sequence. Step 1 is D for danger. You have to check your environment. Is there a live electrical wire on the ground? Is there oncoming traffic? You simply cannot help a victim if you become a victim yourself. Step 2 is R for response. You're checking the patient's response specifically by feeling for that carotid pulse and looking for breathing for about 5 to 10 seconds. Then, step 3 is S for shout for help. You need to activate the emergency response system or point to someone specific to do it immediately because you are about to be incredibly busy. Section 3. Chest compressions by age. The C in KBD. The core of modern CPR is summarized in this acronym, CABD. Begin chest compressions, open airway, give breathing, and use defibrillator. Notice how compressions comes first? That's because medical science has shown that manually circulating whatever oxygen is already left in the blood up to the brain is the immediate overriding priority. The C is where the actual physical life-saving labor begins. And when you start those compressions, you must lock your brain into this number, 100 to 120. That is your strict target rate of compressions per minute, regardless of who the patient is. 100 to 120. It's a brisk, very steady rhythm. You're pushing hard and you're pushing fast to literally act as the patient's heart. And our source material brilliantly illustrates how our technique has to adapt based on the size and age of the patient. For an adult, so anyone over 8 years old, you check the carotid pulse in the neck. You're using 2 hands with interlocked fingers, compressing the center of the chest right between the nipple line to a depth of 2 inches, which is about 5 centimeters. But jump over to a child ages 1 to 8. You can check the carotid or the femoral pulse in the leg. You drop down to just using 1 hand to compress, but you still need that full 2-inch depth. Now, if it's an infant under 1 year old, everything shifts. You check the brachial plus in the arm or the femoral. Your method changes drastically to just using 2 fingers or 2 thumbs. The depth decreases to 1.5 inches, and your physical landmark shifts slightly to just below the nipple line. As the anatomy changes, the actual mechanics of your rescue have to change right along with it. Section 4. Airway and breathing maneuvers. The A and B. After your compressions, to give artificial breathing, you obviously need an open airway. The crucial point here is knowing exactly how to open it safely. The notes highlight a massive distinction. The standard maneuver to open an airway is the head tilt chin lift. It is exactly what it sounds like. However, if there is any suspected spinal injury, let's say the patient fell from a roof or was in a high-speed car crash, tilting their head could cause catastrophic spinal cord damage. In that specific scenario, you must use the jaw thrust maneuver instead. This keeps the neck perfectly immobilized while still opening up that airway. Once the airway is clear, we move right into breathing. The notes detail that an artificial oropharyngeal airway device can be used if you happen to have one. If you're doing this manually, methods include mouth-to-mouth, mouth-to-nose, or mouth-to-stoma. In a clinical setting, an ambu bag is the standard go-to. But check out these medical parameters. Your target ventilation rate is 10 ventilations per minute. And here's a seriously fascinating fact from the clinical data. When you provide manual rescue breaths, you are giving the patient about 16% oxygen. Normal room air is 21%. So your exhaled breath actually contains more than enough oxygen to sustain their vital organs, provided you are compressing that chest effectively.
Section 5. Compression to ventilation ratios. Sustaining the effort.
Now, what's really interesting about this slide is how the mathematical ratio shifts depending on who you are rescuing and how much help you have around you. For an adult, whether you're totally alone or with a partner, the ratio is locked at 30 compressions followed by 2 breaths, 30 to 2. But for a child, if you're solo, it's 30 to 2, but the very second a second rescuer arrives, that ratio drops to 15 compressions and 2 breaths. Why the change? Because pediatric cardiac arrests are much more likely to be caused by respiratory failure, so they desperately benefit from more frequent ventilation when the extra manpower allows for it. And for a neonate, a newborn, the ratio tightens all the way down to 3 compressions for every 1 breath, no matter how many rescuers are present. And wrapping this up, the source material explicitly commands us to change the position of every rescuer after 5 cycles, or roughly 2 minutes. Look, high-quality chest compressions are absolutely exhausting. Your physical fatigue will quietly degrade the depth and the rate of your compressions without you even realizing it, and that directly reduces the patient's chances of survival. Swapping out every 2 minutes ensures that the patient is always receiving maximum effort. So we've decoded the clinical notes, we've mapped out the framework: danger, response, shout, compressions, airway, breathing, defibrillator. So I'll leave you with this final thought. When seconds matter and the pressure is completely on, will you remember the DRS-CABD sequence to save a life? The structure is right there, waiting for you to use it. Thanks for joining me on this explainer. Stay focused, stay curious, and I'll catch you on the next one.